Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron, and I'm joined today by Dr. John Komen, orthopedic sports medicine and joint replacement specialist. Today, we're going to talk all about knee pain and ways to get relief. So, if you are dealing with pain, an injury, or arthritis in your knees, then stick around, share this broadcast with your friends, and ask your questions in the comments below. We'll answer as many as we can. Welcome, and thank you for joining us, Dr. Komen. Before we get started with the knee pain questions, will you please tell our viewers a little bit about yourself and your specialty?
Sure. My name is Dr. John Komen. I'm a board certified orthopedic surgeon with a specialty in sports medicine, fellowship trained. I've been practicing since 2000 in the Baltimore area. I originally had a practice for 10 years in my own practice of Komen Orthopedics and Sports Medicine, and recently joined MedStar in November of 2024.
Awesome. Thank you so much. Let's dive into our questions. Knee pain is fairly common, but what are the typical signs and symptoms that someone should look for? And when should they consider getting their knee pain evaluated by a doctor?
So knee pain can affect anywhere in the knee joint itself. You can get front knee pain, pain in the back of your knee, pain on the sides. It can sometimes cause swelling. Sometimes you get some popping and clicking, some what we call mechanical symptoms. Sometimes there's just limited motion and inability to bear weight. It can be that bad. So those are things to kind of look for. If it's sort of achy or stiffness, that's another symptom that you can kind of, think about as maybe arthritic symptoms. And those are kind of the things we look for in the office too.
Okay. Can you explain the basic anatomy of the knee so that we can understand what causes these different conditions?
Well, the knee joint is a joint, so it has cartilage surfaces, which are very smooth and glass-like. There is structures that sit in between the two bones called the meniscus. You have a medial meniscus and a lateral meniscus, and those help absorb a lot of the energy transmission through the joint. They're sort of the shock absorbers of the joint. You have ligaments in the center of the knee called the cruciate ligaments. There's anterior front part and posterior in the back part that sit in the center of the knee, the cruciate ligaments. The collateral ligaments are on the sides of the knee. And I happen to have actually, if you guys can see that
Oh, nice.
right there. So you can kind of see we have the lateral meniscus here, medial meniscus here, cartilage surfaces on the ends of the bones. In the center of the knee is the cruciate ligaments. The kneecap also is sitting up here, and that is also has cartilage surfaces too. And so those are all the major structures of the joint.
That's really helpful. What are some of the causes of knee pain?
So when we think about causes of knee pain, you have to think about sort of the anatomy of the knee, what structures can cause those pains. And so the most common thing we see is obviously arthritis of the knee, which can be fairly generalized at times, but sometimes localized to certain parts of the knee. You'll get stiffness from the arthritis. You may get some swelling, and it may get some grinding in the knee as well. The meniscus sometimes can tear, which if it tears, then it also becomes a source of pain. It also can make some noises. It can pop and click at times. Squatting, if you have a meniscus tear, is very difficult. So those are other things. Cartilage underneath your kneecap, that sometimes can cause some of the pain when you go up and down steps. That can also cause some grinding as well.
Okay, thank you. Are there any risk factors that make someone more likely to experience knee pain?
Well, there's a lot of factors. Obesity is certainly a factor. I think if you load the knee too much, if you're extremely overweight, that loading really puts a lot of pressure through the joint, and that can cause some pain just in and of itself. And for every pound you lose, you take 4 pounds off the knee. So that's kind of what I tell patients, not just pound for pound. So we always have to look at, obesity as a risk factor. Unfortunately, it is. Sometimes genetics is a factor too. If arthritis runs in your family, then you may have sort of a genetic predisposition for arthritis in the knee. There's certain occupations that are also not the greatest for your knees. So if you're on your standing all day long, or if you're doing a lot of heavy lifting at work, those are things that sometimes can cause some knee pain. Some sports also are high propensity for knee injuries. Anything with high impact, such as football, a lot of twisting, so soccer, and then those that I played baseball, so I was a catcher, and so squatting always, that's certainly a risk factor for getting knee problems as well.
Okay. What are some things patients can do to relieve knee pain on their own before they call a doctor?
Yeah, I mean, I think if you start getting some aches and pains in your knees, you may want to try some of the over-the-counter anti-inflammatory medications to help reduce any irritation you may have. Icing the knee at night sometimes is beneficial, and sort of modifying your activities. So if you're doing a lot of running and all of a sudden you start noticing a little more knee pain, you may have to curtail your activities. For marathon runners, they just want to run, 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 but a lot of times that will start to actually cause more pain in your knee. And so I often tell patients that they need to sort of modify their activities and cross train. So you can do some swimming, biking, walking, things that aren't constantly pounding on your knee. And then they slowly get better over time. So you just sort of modify your activities.
Okay. So if someone decides to call you, what does the diagnostic process look like?
So, the once they see patients in the office, you obviously take a thorough history. The history includes whether they had any injury to their knee, or whether it's just been recently bothering them, or whether it's been a long-term problem that they had. Or they've sometimes had a prior injury in the past that is starting to come to bother their knee a little bit more. So the history is important, where it hurts. So we have like an idea in our mind. We also made this. So there's certain areas on the knee that can cause pain that we look for. So medially based pain can be your meniscus, can be the cartilage, can be the ligaments, and the ligaments in the center of the knee, the cruciate ligaments, mostly for trauma or sporting injuries. Those are things that can cause some of the pain. And the lateral side of the joint, you can also get some bursitis on the side, or in the front of the knee, you can also get patellar tendonitis or quadriceps tendonitis. Again, sometimes those are things from the overuse that you get. So the history is very important. We usually get an X-ray just to look to see if there's any early arthritic changes. We look for the alignment of the knee joint itself, because some people are more of a load on one side of the joint than the other, and that can predispose you to early wear on that side of your joint. Sometimes their kneecaps aren't always aligned properly, and we can kind of see if their kneecaps being tugged a certain way or sits a certain way that's abnormal. And so those are some of the diagnostic things we do. If it's bad enough, or we want to get a better view of the soft tissue structures, then we'll usually get an MRI of the knee, which shows me what the soft tissue structures look like, such as the ligaments, the meniscus, cartilage surfaces, the tendons about the knee. And that will give us a lot better idea of what's going on. And sometimes it's very simple. We can usually draw a diagnosis maybe just from the history and the X-ray alone. Other times we may need the MRI.
Wow. There are so many different things that can go on with the knee. I had
Didn't think so.
yeah. Is there anything that people can do to delay or prevent surgery? We haven't really talked about surgery as a treatment option yet, but is there
Well,
anything?
I mean, it kind of depends on what their diagnosis is. Certainly arthritis, we usually always treat that non-surgically first with different modalities, such as, physical therapy, exercise, activity modification, anti-inflammatory medication. Um, Physical therapy would be a benefit too, and sometimes injections. So sometimes we do cortisone injections, or what's called lubrication injections, or visco supplement injections. And that's to lubricate a joint that may be arthritic. Because in an arthritic knee, the normal lubrication is not functioning properly. By adding proper lubrication, it takes away some of the stiffness and pain that you get from arthritis.
Okay, that's good to know. So thank you, Dr. Komen. At this time, I'd like to pause and welcome our viewers again. Thanks to everyone for tuning in. We're talking all about knee pain and ways to find relief with Dr. John Komen, orthopedic, sports medicine, and joint replacement specialist. So far, we've shared the anatomy of the knee, causes of knee pain, and the diagnostic process, but we have more to discuss, so keep watching. Share this Facebook Live with your friends and send us your questions in the comment section, and we'll respond to as many questions as we can. So let's dive back into some more questions. Can you describe the variety of conservative treatments available?
So, like we talked about, there's certainly physical therapy modalities with muscle strengthening exercises that physical therapy can do. They can work on, certain techniques for if you're walking poorly or your posture's poor. That's certainly ways that physical therapy can be of benefit. There's injections for the knee, like we talked about, cortisone or a viscose supplement injection for arthritis. Um, there are certain anti-inflammatory medications that we can use. Sometimes we rely on bracing. So if you tend to really put a lot of pressure on one side of the joint by giving a brace to sort of support you on that one side, that may be a benefit as well.
Okay, those are helpful. Moving on to surgical options, what is the difference between arthroscopy and knee replacement?
Big difference. So a knee arthroscopy is where we actually use tiny little incisions to look inside the joint through a camera and actually can see all the parts of the knee joint itself. And so that will allow us to visualize what's going on without making a large incision. Before knee arthroscopy, back in many, many years ago, we relied, you had to do an open, what we call an arthrotomy, where you actually open the joint and you had to just kind of look inside. You didn't have the ability to have a scope. Now we do, where we can actually look in the recesses of the joint and really see if there's any loose bodies and get an idea of what the ligaments and meniscus looks like. It really gives us a lot better visualization of the joint itself. And then at the same time, once we do a diagnostic arthroscopy, then we have instruments and tools that we use to actually fix or debride some of those parts that need to be fixed. As far as an open procedure, a knee replacement is not done arthroscopically. It's done through an open incision where we actually open up the joint and are able to put caps on the ends of the bones and plastic in between. That's what a knee replacement is.
Okay. So you would maybe need an arthroscopy after an MRI just to learn more about what's
Well,
going
if the MRI is really going to give us the diagnosis, so if you had a meniscus tear by MRI, we're going to scope the knee, look at that meniscus, either fix it or debride or trim it out, that portion of it that's bad. We
on.
don't want to usually trim out the entire meniscus because that's bad for longevity of the knee. But if there's bad meniscus that's causing some of the symptoms, if we can just trim out that bad portion and leave behind healthy meniscus, then patients do a lot better with pain, function, and down the road, hopefully avoid arthritis.
Okay. Can you describe some of the common knee injuries that would result in needing a surgical repair?
So the most common repair that I see is dealing with the meniscus. We see that probably the most common diagnosis that orthopedic surgeons encounter is the meniscus tear. So there's two meniscus, there's a medial meniscus and a lateral meniscus, and those both can tear and cause symptoms, pain, difficulty functioning, squatting, or sometimes there's a loose flap that can catch and act sort of like a rock in your shoe, essentially. It just doesn't feel right and it's painful. So by going in and arthroscopically trimming out that loose fragment, then we can actually get patients better and back to their regular functional activities. Sometimes there's loose bodies that can collect. If a piece of cartilage from the end of the bone flakes off, it grows in size, and sometimes those loose bodies can also catch like a rock in your shoe. Take those out, and patients feel a lot better. The other things that we see most commonly are also cruciate ligaments. So the most common is the anterior cruciate ligament, which can tear most commonly from sports that require some twisting, usually a non-contact type injury where the patient plants on one leg, goes to twist on that leg, and then feels a pop. And that pop is the actual ligament that's been ruptured.
Thank you.
I'd say something.
Do you
So,
have, oh, sorry, go ahead.
so in those cases where the ACL tears, we would get an MRI to look to see what the condition of that ACL is. But also sometimes you get concomitant injuries, such as a meniscus that can tear at the same time, or such that cartilage can be damaged as well. And when I say cartilage, I mean the cartilage on the end of the bone. It's sort of that white stuff that you see on the end of a chicken bone. That's cartilage. So we have that same cartilage on the end of our bones, and sometimes that can get damaged. So those are, when those things happen, if those patients damage the ACL, damage the meniscus, damage cartilage, those are all things that need to be treated most of the time surgically if they want to get back to their regular sporting events, sporting activities.
Okay. I do have a question from our audience. Maria asks, what if you have pain with pivoting?
Yeah, I mean, I don't know what Maria's age or activity level is. Pivoting can be a source of many different problems, but pivoting could be a meniscus problem.
Okay.
If you've had a sporting accident where you've actually, like I said, planted or twisted your knee, then pivoting is more difficult. Some people, don't even know they had an ACL injury because sometimes they kind of go not as painful. You go, oh, I think I may have done something, may have tweaked it, and they have just a little partial ACL tear. That sometimes can cause problems with pivoting on the knee as well. And then other times it's just arthritis that, has some wear and you have a little cartilage that may be causing some problems and you go to twist or turn on your knee and that can cause pain as well. So pivoting can be caused by many different sources. You'd have to sort that out with a history, physical examination, and then diagnostics as well.
Okay. Okay. She also asked, how long does it take to be seen in your office?
We'll get you in as soon as possible. It depends on the schedule, but usually, within a week.
Perfect. On to my next question. If you have an injury to one of my knee ligaments or tendons, and we decide together that surgery is the best option, what are some of those options?
Well, let's take, for instance, the patellar tendon. That's the tendon that sits in the front of your knee. It connects your kneecap to your leg bone, the tibia. It also enables you to extend your leg. So when you straighten your leg out, that's what you're using as your patellar tendon,
Like looking
along
at
with
my
your,
knees,
right.
thinking where these things are.
So that's it right in the front. And if you injure that tendon, you need to get it fixed because without it, then you may not be able to fully extend your knee. So in those cases where, we'd get the x-ray, pretty much you can make the diagnosis by the physical examination, which you feel a defect of that tendon off the bone. You'd still get an MRI just to be sure and verify. But in those cases, the best choice for that is really to have it operated on and you fix the tendon back to the bone where it belongs. And then it allows you to get that tendon to heal where it needs to so it can function the way it's intended to. If you don't, then that leaves you with sort of a gap between the bone and tendon, and then you're left with an inability to fully extend your knee. So that's not a good option. So there are some options where you need surgery for that. ACL is always the ACL ligament that sits in the center of your knee. It depends on those things are not mandatory to have surgery. Sometimes if you're willing to modify your activities and you don't have any other significant problems with your knee, you can live without your ACL. But if you go to twist or you go to really do a high sporting activity that requires twisting, then you can injure other parts of your knee. So you have to really sort out what you plan on doing with your knee and to see if that's something that you're willing to do is the modifier activities. Now, most of the time people aren't, so they want to get back to what they were doing before, and so you'd reconstruct it. Sometimes you can repair it, but that's another conversation. But the most of the time, unless you're willing to modify activities or your age sort of you're more mature in age where you just go, you know what, I don't need to play soccer anymore. I'll just stop doing that. Then you can live without an ACL.
Okay. We have another question from our audience. John asks, which I think you mentioned this before, can knee replacement surgery be performed arthroscopically? And I think you said no, correct?
Correct. Yeah, they're done through an incision. We've cut down on the size of the incisions these days. We have sort of a minimalist way to approach the knee joint, but arthroscopically it is done through a scope, and you can't scope an implant into your knee. So that
Mhm.
doesn't happen. So
Right.
it requires an open procedure.
Okay. Thank you. What is the recovery usually like after these types of procedures, the surgical procedures?
So it kind of depends on what you do.
Okay.
So if it's a meniscus surgery that we debride, I usually let patients, weight bearers, tolerate it and start moving their knee when they're comfortable. I don't use a brace for that. And I usually see them back in a week and we get the stitches out and then they start physical therapy. So the recovery is pretty quick. Now, if we fix the meniscus, then I may use a brace for 4 weeks, kind of protect the repair because that's what we're waiting for. We don't want to twist the knee too early, but begin physical therapy usually after the first visit just for motion so you don't get too stiff, but we still protect you with crutches and a brace. For an ACL reconstruction, I usually use a brace for 4 weeks. We usually keep it locked straight at night and then unlock during the day for range of motion. After 4 weeks, you get rid of the brace. And in that particular procedure, I usually start physical therapy 3 to 5 days after the surgery. And then as far as return to activities for an ACL, I usually don't let any patients start running or jogging for 3 months. Full activities at 6 months, unless you're playing pivotal sports, then I wait 9 months.
Wow.
So it's a longer procedure because when we do the reconstruction, the ligament we use it has to regain blood supply,
Mhm.
has to heal in first. If you load that ligament too early, then it could prematurely rupture again, which we don't want. So we want to have the body heal that ligament, get a new blood supply, really mature over time, and then it can start loading again.
Wow.
And that's all done through research. It's been done on how ACLs heal.
Speaking of ACLs, if I were to injure my ACL as a young athlete, for example, does that mean I'm more likely to need a knee replacement when I get older?
This is one of those questions that I get asked, and it kind of depends on other injuries that you have. So if you have a meniscus tear on top of an ACL tear, there's certainly a higher likelihood of getting arthritis in your knee. But the moment you impacted the two bones together to rupture your ligament, you probably did some damage to some of the cartilages, the cartilage surfaces of your knee. And in those cases, and we don't know when and if it's ever going to occur, but you're at a higher likelihood of getting arthritis in that knee than if you had not sustained any injury.
Wow.
So when it happens exactly, we don't know. And a lot depends on your genetics, how you heal, and how much impact that cartilage surface really took during the initial injury.
Okay. Wow. We have another question from Deborah. I have bone on bone knee pain. I don't think I qualify for surgery because of weight. I'm in a lot of pain. She takes tramadol for the pain. What are her options for pain relief while she works on her weight loss?
Well, I mean, certainly if you got bone on bone, a cortisone injection may help some of the pain you're having. Sometimes we'll try a visco shot if the cortisone doesn't work, or sometimes we'll just try the visco shot and see if those things can help alleviate some of your pain. The biggest thing is your BMI, your body mass index. So depending on your height and weight, that we have to look at that and really consider a well-structured weight loss program to get some of that load off your knee, which you may feel better just from that alone.
Okay, that's helpful. Thank you. Karen asks, I was just diagnosed with a stress fracture on the outside or front of my tibia near my knee. X-rays did not show it, but MRI did. I've been told to rest my leg and heal the bone. Any other suggestions? Thank you.
Yeah, these are called insufficiency fractures. And you think of a fracture as like a broken bone, like outside, but this is actually dealing with the marrow of the bone that just gets stressed out. And that's why you can't see it on an X-ray, because the
Okay.
X-ray is just kind of giving you an idea of the overall picture of the bone. But the MRI really shows us what the bone marrow looks like. And it sort of lights up on the MRI when you see these. And it's a insufficiency fracture because the marrow of the bone is just not supporting it as well, and it becomes a source of pain. So it takes time for those to heal. What I usually do is put patients in a brace to support the knee, still once you're moving it, but if it's bad enough, sometimes you may have to use crutches or a walker to kind of get around until your body starts to heal that up a little bit more. There are some patients, some people who, or some physicians who will do injections into the bone where they're injecting cement, which helps support it. That was one of the ideas. I don't know if that's a great idea these days. I think you're better off sometimes just waiting it out, supporting, using the bracing and the crutches of some sort to kind of just let your body catch up and heal the bone.
Okay. Thank you. You mentioned the injections, so cortisone and did you say visco?
Visco shots, yes.
So Kathy asked, how often can you safely she asked cortisone shot, but I think.
So cortisone, I'd say you can get it every 3 to 4 months if you
Okay.
need it. You don't want to just keep injecting just because it's time for it. So you have to see whether you get a response with the cortisone, and you have to see whether it really, if it's time for it. You don't want to go too early because then that causes problems. You have to really evaluate how effective it is long term,
Mhm.
because sometimes it may be that you may have to consider other treatment options for your knee outside of just the cortisone alone if it's not helping you.
Okay. Good to know. So Deborah had asked about her knee pain and said she didn't qualify because of her weight for surgery. And so then Rhonda asked, she was curious about how weight prevents surgery.
How
How her weight would put off surgery.
Well, the thing we worry about if you're talking about a knee replacement is that you don't want to overload your implant, which can cause premature wear and cause premature loosening of your prosthesis.
Okay.
So that's what we worry about the most. You also have to be mobile enough to really rehab your knee.
Mhm.
Rehab is one of the most important things you can do for a knee replacement. If you don't have good rehab or are unable to do the rehabilitation, then your outcome is going to be really compromised.
Okay. Thank you. That's helpful. Let's go back into our questions. What conditions lead patients to consider knee replacement?
So most commonly is osteoarthritis, where you actually have the cartilage on the ends of the bones start to wear away, much like the treads on your tires. They start to lose the cartilage surface, and it just creates a very non-smooth surface. So the cartilage we talk about is what's called hyaline cartilage. Hyaline means glass-like. So if you can imagine two pieces of glass moving back and forth, if it's nice and smooth and glass-like, then it's going to glide easily. So that's what normal cartilage looks like. If you put scratches and dents to that glass and then put those two panes of glass together again, they're not going to move as smoothly and glass-like as you want. So that's what happens over time, is that cartilage just starts to really become uneven and not smooth, and just that's why you get stiffness and pain because of that. So osteoarthritis is one thing. Some people have rheumatoid arthritis, which is an autoimmune phenomenon that affects the joints, and that can also affect the synovial lining, which is kind of eating away at the bones sometimes, and affects the cartilage surface as well. Those are things to maybe consider for knee replacement. If you had any post-traumatic injury, so if you had a fracture, like a tibia plateau fracture, the plateau is part of the tibia that goes into the joint, and that if that's fractured, then you sometimes get what's called post-traumatic arthritis. And that can lead to arthritis where the knee just doesn't function properly. It's just not smooth and glass-like. It causes pain. You can't bear weight. You can't walk distances that allow you to really function the way you want to function.
Can you please explain the different types of knee replacement surgery?
So the most common one we use is a total knee replacement. And what does that mean? Total meaning that there's 3 compartments to the knee. I'll show you my picture again. So there's 3 compartments to the knee. There's a lateral compartment, a medial compartment, and a patellofemoral joint compartment. So those are your 3 compartments. In a total knee replacement, you're replacing all 3 compartments of the knee. So essentially putting caps on the ends of the bones of the femur and tibia, and then plastic in between and plastic on the undersurface of your kneecap. And that's how you do a total knee replacement. So that takes care of all cartilage surfaces in your knee, you won't have arthritis in your knee again. In a partial knee replacement, you're only replacing one compartment. Most commonly is the medial compartment. And that's where we just essentially put metal on the end of the femur, metal on the top of the tibia, and plastic in between in that one compartment. So that leaves the patellofemoral and lateral compartments, which are still viable and healthy, to still function the way they're intended to. So in the partial knee replacement, you're not filling with any of the ligaments. It's a smaller incision. The recovery time is a little easier for a partial knee replacement. In a total knee replacement, you're taking at least the ACL out. That's in the middle of the knee, and you're doing a larger incision, a lot more invasiveness, you could say for the knee, and so the recovery is a little longer for that.
Mhm.
One other type of partial knee replacement we do is a patellofemoral joint replacement, where we see the weight-bearing portion of your joint is fine, but your kneecap is really arthritic. You can't go up and down steps. You can't function too well. And if the other compartments are really healthy, and the kneecap is not allowing you to function, then you do a partial knee replacement of the patellofemoral joint.
Okay. That's great information. I've known someone who put off surgery for years only to say afterwards that they wish they had done it sooner. Is that a common response you see from patients? And how do you know if it's the right time to get a knee replacement?
Yeah, I mean, to make a patient go through a major surgery, they have to be ready for it mentally.
Mhm.
And some patients are just tired of dealing with their knee, tired of having the pain, the limited function, and they just kind of go with it. They're like, I'm tired of this. Let's just get it done. Other patients, symptoms aren't too bad. They can kind of deal with it. We deal with it non-surgically with injections, physical therapy, and all the usual things. And then they kind of if they can live with what they have, they live with it. But as time goes by, if they start noticing more activity levels dive down, they're not as active as they want to be, they're having more pain, less motion of the knee, then those are things time to say it's time to get that. But yeah, I do get patients who, if they're bad enough, they want it done sooner than later. And for patients who finally get it done, they're like very happy. So, knee replacements by and large are, 90 to 95% effective for relieving pain and allowing full function of the knee. And those are good numbers to hang your hat on. And I think as we get more educated on where the implant goes and how we can put it in a lot more accurate, then those numbers will continue to improve.
That's awesome. If arthritis tends to get worse as we age, how often do patients need to get their other knee done or a hip after they've gotten a new knee?
Um, every knee is different, so they behave differently sometimes. You may have a knee that has some bad arthritis, but the other knee is minimal but has more pain. So you kind of have to listen to how your knee is. Just because you had a knee replacement on one side doesn't automatically mean you're going to have it on the other side. There are things that can happen on the one knee that needed a knee replacement, such as trauma, such as injury, things that may affect it differently than the other knee. So those are things that you have to kind of look at the big picture, but I wouldn't condemn your other knee just because you had a knee replacement on one side.
Okay, that's good to know. Is it possible to get both knees replaced at the same time? And are there pros and cons to doing that?
Um, by and large, I usually tell patients you probably want to do one at a time. But in the small circumstance of patients that I have where both knees are just so horrible, where they're not going to be able to rehab the one knee because of the other knee, and it's going to affect the outcome of that one knee, then I'll say, let's do both at the same time. But you have to realize when you do both at the same time, you're going to have two joints that are recovering. The amount of pain you're going to be in is going to be more because you have two joints. And usually you have to have rehabilitation. Usually I have the patient stay in the rehab facility until they can get a little more functional, till they can actually start getting up and by themselves, getting up and moving by themselves. And that sometimes takes a week of rehab too. That being said, I have some patients who stayed overnight and went home the same day. So, but it's all in the expectations that you lay. So you have to kind of expect that. And if you're doing better, then you just go home.
Okay. What should knee replacement patients expect in terms of recovery? You've touched on it a little bit.
Yeah, I think I tell patients overall it's going to take you probably around 3 to 6 months to fully recover from your knee replacement. Now, that doesn't mean you get to sit on your duff, do nothing. So you're walking from day one to try to learn how to move and walk with your new knee. Usually by 6 to 8 weeks, the soft tissues really start to heal. And so you start to feel a little better where you get more function, more range of motion to your knee, and less pain, obviously. And then it's a matter of getting the strength and the function back down the road after that 6 weeks. Then you're really kind of moving. But some patients are by 2 months floating around and doing fine. Others, it just takes a lot longer. It kind of depends how your body heals. Some patients heal with a lot of scar formation, and that's genetics. We can't do anything about that. So if you're a big scar former, keloids, things like that, those patients are probably going to take longer to heal, and sometimes they get stiffer too.
Okay. What is the typical life expectancy of the hardware used for the knee replacement?
So I tell patients anywhere from 15 to 20 years. When I first started practice, it was about 10 to 15 years. But I think the technology is advanced enough where the plastics that we use are a lot more durable. We're able to put in the implant to have a better balanced knee. In some of the older techniques, you couldn't balance the knee out as well, and you sort of edge load or load one side of the knee joint versus the other. And those are things that can really bear out on the longevity of that implant. So if we can put a well-balanced knee with sort of the high durable plastics that we use, then I think the longevity, we could safely say around 15 to 20 years, but it may be more than that. So it
Okay.
kind of depends. Some of the plastics, we've used vitamin E fortified plastics, which vitamin E is a free radical scavenger. So it helps get rid of those free radicals that sometimes causes early degeneration of that plastic. And so by embedding the plastics with the vitamin E, it makes it more durable too.
Okay. That's good to know. Long term, do patients after having a knee replacement have to make any lifestyle changes?
Well, they probably made already lifestyle changes from their arthritis.
Mhm.
So if anything, they're probably going to have more activity levels improving as they continue to recover from the knee replacement. But that being said, if you were a singles tennis player, you probably still shouldn't play singles. You'd probably play doubles tennis. Impact wise, low impact activities are probably going to be better longevity wise for your implant. And that's where, I tell patients don't go jumping out of planes and don't think that you have a brand new knee that you were born with, because you still want that knee to last. So we still want to have something that's, in 15, 20 years, we can say still going good, and those are things to consider. But it doesn't mean I don't want you active. I want you active. I want you exercising so you can exercise in the gym. You can golf if you want to golf, swim. Riding a bike is fine. But for a real high marathon running, no. Those are things that probably not a good thing for your knee.
Okay. We have another question from our audience. Lindsay asks, over the summer, I had a complete tear of my medial meniscus at
Mhm.
the root and surgical repair. I'm 46 and now have some arthritis and damage. Have any advice on stem cells, trying to avoid knee replacement anytime soon?
Well, I guess the first question is, did the medial meniscus root heal and is in good position? Because that is repaired to hopefully uh, prevent further arthritic changes in your joint. Because if you didn't have that fixed, your rate of arthritis really goes up in that compartment. So I'd see if that was healed for a follow-up MRI. And then you can also look to see how much arthritis you have in that compartment. As far as doing in different types of injections, what type of injection did she say? She said,
She asked about stem cells.
yeah, stem cells. I mean, that's for the arthritis, and obviously not covered by insurance, so that's going to cost a lot of money. And for the patients that I've seen who've had those, it may give you some relief, but not completely. So at some point, depending on how much arthritis you have in that compartment, if the other parts of your knee look fine, it's just that medial compartment, it may be a unicompartmental or a partial knee replacement could be a benefit there. I wouldn't I wouldn't spend a lot of huge sums of money on doing the sort of non-covered injections.
Okay. Similarly, Deborah asked about plasma treatment.
So plasma, I think she means what's called PRP. Platelet-rich plasma is one of the other things that you can try injecting into an arthritic knee joint. Some patients get temporary relief with that too. Again, not covered under insurance. So it's a little less expensive than the other injection. But again, I wouldn't hang my hat on that thinking that you're going to be 100% and it's going to take care of all your pain for a long term. These are things that can temporarily help you. But if you're looking for a long-term fix, then replacement may be the better choice. Again, it depends on your circumstance.
So call you and make an appointment.
Yes.
We have a question from Michelle. My knee has felt very unstable and painful during skiing, but in everyday life, I've been strengthening in the gym and it doesn't usually hurt. What type of knee condition can lead to instability?
Well, I mean, if you're skiing, you always worry about the ACL, the anterior cruciate ligament, and whether you've had some spills that may have stretched out your ACL, or maybe you had one where it popped and you didn't even notice it because you were so cold and kind of who knows what happened during that time. But like I said, some ACLs don't have other injuries, it's just a pure ACL. And so that may cause a little bit of instability in your knee that you're not going to bring out during normal activities of daily living. You're going to feel it a lot more with skiing because that's side to side. That's a lot of pivoting on your knee. As soon as you go to pivot, if that ACL is not there, you're going to feel it. So a lot of times we'll get an MRI to see what the condition of your ACL is, see if there's any other things that can cause some of the pain with pivoting, because you could have a meniscus tear too.
Thank you. Are
Mhm.
there any other common questions that you get about knee pain in your office that we haven't discussed yet?
Well, anterior knee pain is one of the things that we see pretty commonly, and it can stem from the cartilage surface underneath your kneecap, what's called patellar condymalation, which is truly not arthritis, but it's a soft cartilage. And some people feel it's sort of a precursor to arthritis. Um, Across your kneecap, there also can be an imbalance of the forces on that kneecap. So there's muscles that keep that kneecap centered in good position, and sometimes those muscles get out of balance. And so that can cause anterior knee pain, which you wouldn't think, but can be very quickly fixed with physical therapy. And so those are things that we look for. Sometimes just the alignment of that kneecap and what you're born with. Some people have an attachment point that is sort of more off laterally that can cause a lot of uneven wear across your kneecap. Those are things we can look for as well that can be a source of anterior knee pain, because that is a very common thing we see in the office.
Okay. What about new technology on the horizon? What might we see in the future?
So I think, right now we're using technology with 3D printing technology to actually make custom knee replacements. We're using robotics to actually put the knee on a screen to see where you're going and see if the cuts are accurate. One thing that's also on the horizon is what's called augmented reality, where much like the video games that you see kids playing, they have now goggles that we can wear intraoperatively that will allow me to see the knee in 3D spatial orientation and can actually see where I'm going in the 3D knee,
Wow.
which I find is pretty cool. But I haven't had time to play around with that yet, but that's one of the biggest things. The other thing we see in the implant itself, there are some sensors that they can put in the actual implant, and those sensors can see how you're recovering from your knee replacement surgery. And so that gets feedback to a computer that can actually sense how you're recovering, whether your motion's coming along, your gait, how you're moving. And those are things that, on the fly, you can make adjustments for your rehab where we're looking a little slow there. Let's see if we can, get a little more motion, see if we can work on getting your full extension because it can sense whether you're getting the right motion or not.
Wow. That's very exciting stuff.
Yeah.
We have another question from Kathy who says she's diabetic, and for quite a while now, my right knee is hurting so bad. Trying not to take over-the-counter pain meds, but my life is getting harder and smaller. I need help.
Make an appointment. No, but I would say, if you're diabetic, the thing you have to watch out for with cortisone injections is that they can elevate your blood sugar. And transiently, it'll go down over time, but certainly if you're really out of control with your sugars and not keeping tight control, you don't want to do a cortisone that can make it even worse. So those are things you have to consider when you're diabetic. Those are, as far as what's causing your knee pain, that's something that has to be evaluated, whether you have sort of arthritis already or not. But if you have arthritis, then you may be a good candidate for a visco supplement injection, which avoids the cortisone blood sugar issue and allows, for some more pain relief. And sometimes physical therapy may be a benefit too.
Okay, great information. Thank you.
Mhm.
Another question from Barbara is how to heal a Baker's cyst. I've not heard of that.
So what is a Baker's cyst? A Baker's cyst is an outpocketing of your capsule in the back of your knee. So usually it stems from a meniscus tear that sort of has a rent in the capsule joint, and then it leaks fluid out. When your body senses that leakage of fluid, it tries to wall that off. And in so doing, it creates this cyst in the back of your knee. You've probably heard the same thing happens in the wrist. You've heard of ganglion cyst. That's the same idea. That's the same thing that can happen. So this is a popliteal cyst or Baker's cyst in the back of your knee. So ways to treat it, there's three things we could do. You could do nothing if it's small enough and not causing problems. Sometimes if it is causing some pain, you could suck some of the fluid out and kind of decompress the balloon. And then certain times you have to sort of fix the pathology. So an MRI of the knee would be beneficial to see if there's any meniscus tears, see if there's anything that may be underlying as the source of that popliteal cyst. Sometimes if the cysts are large enough, you may sometimes excise out the cyst. And that can help reduce a lot of the spatial compromise that you have from that cyst. But it's got to be pretty big. Most of the time, it's an indication of some sort of intra-articular pathology causing that popliteal cyst.
Okay, great. Thank you. A question from Diane. I've heard after total knee replacement, you are unable to kneel or crawl on the knee. Is that correct?
Well, I think for a short period of time, you can kneel. I wouldn't go gardening on your knee again and putting a lot of pressure on that kneecap because the kneecap has a piece of plastic on its undersurface. You don't want to wear that out or crack your kneecap. And the other problem is that you have sort of, incision in the front of your knee that can be sore if you put a lot of pressure on it. So patients don't like to put a lot of pressure because of that soreness. But if you really need to do it for a short period of time, you can.
Okay. Thank you. And Kathy asks, is arthritis unavoidable as you age?
Um, I think it's multifactorial. So if you've had some trauma to your knee, if you have poor genetics where, family members all have arthritis, you may be a higher predisposition for arthritis. It doesn't mean just as you get older, you're going to get arthritis. It's not 100% accurate because I see a lot of patients that have, pristine knees that are in their 80s and 90s. So it's not something we can always predict. That's why we say it's multifactorial.
Okay, that's great. I have cracking in my knees. Is that a concern?
That's what we talked about earlier was the patellar chondromalacia. So that's the soft cartilage that you get. And that cartilage starts to become sort of uneven surface and it just creates that cracking. If it's not painful, don't worry about it.
Okay.
If it becomes painful, then that's another story.
Okay, good to
That
know.
probably should be looked at and worked up.
Okay. So we talked about new technology on the horizon. Why should patients choose MedStar Health for their orthopedic care?
When I started Komen Orthopedics and Sports Medicine, I really put patient first as the top of my list as sort of my mission statement to really take care of patients because I think that's the most important thing that we do here. As I joined MedStar in November of 2024, I joined them because they are on the same mission as Komen Orthopedics, and that's to put patients first. And they provide the best care in the area. They're the #1 employer. They take care of the Orioles and Ravens. And who wouldn't want to be treated by that?
Awesome. In conclusion, what's one thing that you most want to make sure people remember from this conversation about their knees?
Don't be afraid to have your knee looked at if you're having problems. I think I see a lot of patients who are just so afraid of what's going to happen if they see the physician that they're going to be automatically treated surgically. And I think most of the time we treat patients non-surgically for most of the knee problems that we see. And so I would say if you have any doubts or any problems with your knees, have it checked out. I think that's the best, safest thing for peace of mind and to see what's going on. And I think that's kind of the take-home message is that, there are ways to treat things non-surgically and surgically, and we can go through it and, together we can figure out a treatment plan for you, whatever you may have.
That's great advice. One last quick question from our audience. Maria asked, and I think this is common, does glucosamine really help? I think a lot of people try that.
Yeah, we're talking about supplements. Early on, I was always doing glucosamine, and that for some patients it does. I also usually recommend what's called undenatured type 2 collagen. It's a 40 milligram tablet, and that also is good for cartilage. It's sort of cartilage health is what I call it. The vets give it to dogs who have arthritis and they limp less and are more active. So, some patients do report back to me that saying that it does seem to work. Is it 100% effective? Of course not. Nothing ever is. So for some patients it works, for some patients it doesn't. And, that's just something that's worthwhile, I think, to try to see if it helps you if you have arthritis. And, if it does, keep taking it.
I just took a note down for my dad.
There you go.
All right. Well, that wraps up our Facebook Live. A huge thank you to Dr. John Komen for spending time with us today and sharing this important information. And thanks to all of our viewers for tuning in and sharing your questions and comments with us. To learn more about Dr. Komen, please visit medstarhealth.org/Komen. And to schedule an appointment with him, please call 877-34-ORTHO. We'll also share all of that information in the comments. Thanks again, everyone, and have a great day.
Thanks for listening.